Right.
We, oh, sorry. That's okay. We know that our body is full of a lot of vasculature and we pump more than 2,000 gallons of blood a day. There is no way that if there is blood coming out of the gums or in the mouth at all, any type of ulceration, that bacteria is not entering the bloodstream. So to think that our entity, the oral physicians, are not medical specialists is crazy to me. And again, we're continuing to make progress in that, but we're still kind of out on an island by ourselves. We also know that 50% of heart attacks and strokes are caused by an oral infection, whether that's periodontal disease or an abscessed tooth. And that, I mean, when you think that 50% of heart attacks and strokes could be due to this oral infection of these types, that's again, we are medical providers. We are oral physicians, oral healthcare providers, whatever you want to call yourself. The term dentist, the term hygienist does not it doesn't hold a lot of value in my opinion. I feel like we need to give ourselves a different title because we are so much more than just a tooth dust maker. I mean, dentist equals teeth, and that's what people think, but we're so much more than that. So again, shifting your mind to really, hey, I'm a medical specialty. I'm a specialist and I focus on this head and neck region and all the structures around it. Now, sleep apnea is in that too. We do a lot of assessment when a patient comes into the hygiene chair or if they're seeing the doctor first for new patient visits. We're so much more than just looking at teeth anymore. And it's that part that really allows us to build to medical. Um, yes, we can bill to medical and we should be billing to medical. We are, the definition of that is anything that we're diagnosing, evaluating, preventing, that we're treating, whether it's surgical or non-surgical treatment, we're treating diseases and disorders of the oral cavity in that maxillofacial area. So that allows us to be able to be considered a medical specialist that can bill to medical. Now, what I can tell you is that medical providers don't like this, and I'm always finding little things that they do to try to deny our claims, make it tricky when providers first start billing to medical. Um, the cool thing is, we actually are the only specialty that has two different reimbursement places to go to. So dental and medical. We can bill to both dental and medical to be reimbursed up to our full fee. And we can't keep a penny over that fee that we build, but that often doesn't happen between the two. So what a great opportunity if you're a PPO practice to try to recoup some of your write-offs that you've had to take by billing it to medical as well. I think one of the biggest things is you have to collect medical cards. And Eben and I had a long conversation about this. And what does that mean? Who can we bill to? Because yes, you are going to be out of network unless you live in a state where there are some of the Blue Crosses that if you're in network on the dental side, you're in network on the medical side. And many practitioners do not know this. And so like Louisiana and Kansas, the FET Blues plans, if you're in the dental space with them, you're automatically in the medical space. And so a lot of practitioners don't know that in those states. There's benefits to both in and out of network, being in and out of network for these payers, but that's a whole nother topic. But as an out of network provider, what you're really going to be looking for is a PPO plan. And you're going to find that the majority of people have PPO type plans that have out of network benefits. Most people want to be able to go and see whatever provider they want of their choosing, who they want to see. HMO and EPOs are going to be a closed network, and you do have to be enrolled as an in-network provider to get on those to even get the payer lists and things like that and be able to provide for those closed networks. So you're going to be looking for medical cards that are out of network benefits. then you can bill to any of those. And Eben was actually running some numbers, and I think he came up with about 60% of the patients in California would likely have out-of-network benefits. So that's pretty cool. And I always knew it was very high because um, this is what I do for a living, and I don't see many HMO or EPO cards come through, but I had never really checked on the stats on that. But it is true. PPOs are always going to be the dominating. People want choices. I think it's really important for us to look at dental insurance as not an insurance policy, but it's a supplement. It is only a supplement. It's a coupon plan, it's a discount plan. It is, at this point of the game, it is maybe a preventative plan. That's it. It doesn't cover much anymore. And I was on um, a weekly thing last night, and they were talking about dental insurance and some of the stats, and it was just staggering and so mind-blowing of how the reimbursements truly have not ever gone up. The allowed amounts are still not changing. They're still only about 1,000 to 1,500 on average, and our costs are going through the roof. And it's not going to be sustainable anymore to be an in-network provider unless you're doing some medical billing. At least that's my opinion on that. It's just getting harder and harder to sustain being in network with insurance, with dental insurance. So another topic again, but I want you to again remember that dental comes with a lot of limitations, exclusions, restrictions, frequency issues that we lose on the medical side. So it's important to know that and remember that because that's gonna come up through this whole presentation. I'm not sure why we limit ourselves to dental reimbursements. I think it's just what we know, and we just maybe don't know how to navigate the medical side of it. When we look at what can we bill to medical, there are so many things that we can bill to medical. And this is just a blanket list. So exams, PANS, CTs, implants, VELscope, obviously, bone grafting, surgical stents, interim prosthesis, wisdom teeth extraction, sleep, TMJ, Botox for TMJ, frenectomies, fluoride varnishes, and again, our advanced oral cancer screening devices. The goal is to try to help increase production, increase our case acceptance, decrease that patient out of pocket, save dental benefits for dental because we can. So I also want you to look at, so there's so many practices doing surgery, and I'm going to break this down for just VELscope too and oral cancer screening, but we're so used to being boxed into I don't know. I just don't even know how to describe it. The longer I'm in the medical side, I just don't understand what we're doing on the dental side. But when we talk about a surgical treatment plan, everything that's on that treatment plan is likely going to be $5,000 or more. So dental, we've eaten up all their dental benefits to say they have a beautiful implant done, and now we don't even have the preventative benefit for them to take care of the rest of their mouth. It doesn't make any sense to me. But that whole surgical treatment is all billable to medical. So right from the evaluation to the imaging that goes along with that, as well as repeat imaging, your grafting, your implants, if implants are covered, the surgical stent to place it, the interim prosthesis, the final prosthesis, all of those things are part of that package that's part of a surgery, just like if you would have any other medical procedure done. So I want you to think more global, think more medical. So what is medical necessity? Because this is the biggest thing that I feel is the difference between medical and dental. In medical, we have to establish medical necessity. That's a scary thing. It's only that we're using diagnosis codes to describe what we did, why we did what we did. So that's all it is. It's nothing more, it's nothing less. We should be doing that on the dental side as well. So medical necessity is just the services, the procedures, the supplies needed to prevent, diagnose, treat an illness, injury, condition, disease, or symptoms. That's it. I often see notes that don't establish that even on the dental side, but that's if you ever get audited, that's what they're looking for, even though we don't have to use a diagnosis code, but that's coming. So it's time to start learning diagnosis codes, and they're not hard, especially when we're only focused on this region of the body. So again, that's our golden ticket. Diagnosis codes establish why we did what we did and our claims process through. Okay. So some diagnosis codes actually include maxillofacial and oral cancer screening, and here they are. These are the two codes for what we are talking about tonight as to how you can get your services covered on the medical side. So we have two diagnosis codes, maxillofacial cancer screening and oral cancer screening, and those are the two. We will not get a claim paid for without having a diagnosis code on a medical claim form. Our program won't even validate it. It'll keep rejecting it. It won't even let it go through. You have to have at least one diagnosis code paired appropriately with the one diagnosis code paired appropriately with the procedure code in order to be for the claim to go through as well as be reimbursed. Now, there are a lot of diagnosis codes, kind of scary, over 72,000 of them. But again, that includes your toes and all of your other limbs and body parts. So it's not, there's definitely not that many for dental, but there is a code for just about everything. Procedure codes, there's also a different procedure code set, and it's called CPT instead of CDT. There are some codes that have a 1-to-1 ratio cross code, but this whole thing of cross coding, that's linear thinking. There are sometimes multiple codes for one dental code on the medical side. So and vice versa. It really just depends on the procedure, like biopsies. So I was working on biopsies today, and man, there's a lot of biopsy codes on the medical side versus on the dental side. So kind of linear thinking. You probably all are wondering, and Evan and I had a long conversation about deductibles. So deductibles, and there's no perfect place to work in the conversation about deductibles. So here it is. The biggest thing to remember, deductibles may not apply to all services. It's very much procedure code driven. And I can tell you, like my insurance, when I go to a physician, I pay a $15 copay and nothing applies to deductible. That's very common on plans to have that. But I'm going to show you a great example of this. And this is actually sleep, on obstructive sleep apnea and diagnostics of that. And this is all done on the same day. And you can see the different procedures on the left: tomographic study, orthopanogram, evaluation, pharyngometry, lateral ceph, and rhinometry that were all performed. You can see what was paid there. The biggest thing is nothing went to copay, nothing went to deductible, only to coinsurance. That was it. Now, on the very same day, we also submitted a home sleep study, and they split this claim. I wish the payer did that. I wish they wouldn't have, so you could see it all on one thing. Now, all of a sudden, that piece of it went to deductible, and nothing went to copay coinsurance. So that's what I'm talking about. It's very much procedure code driven. Here is a surgical case. This was done at the very beginning of a calendar year in January, and this patient had not met their deductible. Everything that we submitted, $33,000, zero went to deductible, zero. And they paid the full $33,300. I can tell you recently I had a large procedure on my pancreas. My total charges, that was in August 30th, By November 14th, I was looking in my portal for my insurance, and because I was curious what everything had added up to, it was over $100,000. I have a $750 deductible, and I had not met it. I hadn't even met my family out of pocket yet, which was, I think it's 18,000. Hadn't even met that. So that's what I'm talking about. It's very procedure code driven. And just like with dental, you'll see different procedure codes break down and have different benefits. Like radiology might have a different benefit than preventative or restorative or whatever. They often have different benefits per category, I guess you could say. I think one of the biggest things that we miss out on is our opportunity for evaluations. That's exactly where that's where diagnosis and medical necessity is established. And I think we're so busy on this hamster wheel trying to get through our appointments, and we have so many tools in our toolbox that we just don't take the time to truly step back and do all of the things like VELscope and the extra things that we need to truly diagnose and treat our patients. This is where I feel like medical billing can help you step back when you can get reimbursed better and you can slow down a little bit and you can just take a breather and be able to truly offer more things that are beneficial for our patients. So I feel like, we're just trying to get paid that $35 that dental's going to pay for an eval. That's insane. I don't know any MD that's going to work for $35.
Hmm.
And I'm going to show you what that looks like. It really does start here. This is where it starts. It starts with this evaluation, and we have to stop looking at just the teeth, okay? Because it's not about the teeth. It is about the teeth, but a lot of the things that we diagnose are a result of other conditions surrounding those teeth. So I also want to show you, this is exactly what I'm talking about when we look at our fee schedules. Those fee schedules are based on the NDAS fee schedules for most practices, and they categorize them by percentages, and we say we want to be in the top 80th percentile. Well, all of those fees came together likely from dental carriers and what they're allowing on for reimbursement. There's no medical component to that. And I don't know any medical physician that would work for $35 is what I see on average for a periodic eval. That is not going to happen. This is what it looked like when my husband went into the hospital with COVID and he was seen in the ER. They billed out $1,619, and you can see our insurance paid $1,133.30. Okay, now get it. I know this was an ER physician visit, but then he was admitted to the floor. Um, excuse me. He was admitted to the floor, and now they billed out $495 times 5 other specialists in that hospital. So in one day, 6 exams were billed out for his care. Excuse me. So what is this phony baloney thing that we have in dental that we get 1 to 2 evals per year? That's what I'm talking about. How many evals do you give away because of that frequency issue? We give a lot away in our profession because of that frequency issue with dental. Evaluations are very, very different on the medical side than on the dental side. I always use the example of a periodic eval. As a hygienist, this always bothered me. I could see an 8-year-old in the morning and an 80-year-old in the afternoon. And if it was a periodic eval, we were reimbursed the same amount. Now, those are very different encounters. That makes 0 sense. So what medical billing allows us to do is be able to say, have a sliding scale for that 0120 based on a medical mindset, how much you have to think, our complexity, and our medical decision making. Is that straightforward, low, moderate, or high? Or the other key component here is time, whether it's FaceTime or non-FaceTime of this encounter. That looks very different. It makes more sense. There's nothing about age. It's all about the medical decision making or the time that we spent with the patient, evaluating and diagnosing. So here are some codes. I'm not going to go into this in detail. We just don't have the time for it. But here's our new patient codes. Here's our established patient, and they're just different by a digit. But you can see on here, and the nice thing is, say we have a very straightforward patient, but in the medical decision making, but we spent 45 minutes with them. Now, that would be, and they were an established patient, you would actually get to go up in your coding and be paid more based on that encounter. So that's the cool part. You actually get paid for the time and energy to diagnose the patient. That makes sense. But it allows us to have a level, say a 0120.2, 0.3, 0.4, 0.5 with a sliding scale that allows us to have different fees based on the complexity of the encounter. So I think that's pretty cool. This is a, I don't have time to show this video, but I'm going to give you the link. I think it is incredibly important as a team, and make it part of your April commitments to do a maxillofacial screening video and training with your team so that your patients are having the same experience with every single with every single provider that does the head and neck evaluation on them. I think that's really important. I see a lot of variation between providers, and I think this is a good month to kind of get on the same page of how does this feel when patients come in? Are they experiencing the same type of maxillofacial and oral cancer screening in our practice from every single provider? So this video will walk you through that. And here is the QR code. I'm part of a co-op with Carry Free, and we just have some really amazing people in our group. And on this page, you're going to find a ton of resources for oral cancer. Every year we do a promo on this, and there's a lot of great resources on this page. So I can always blast this out after the webinar as well. But the cool thing is, you guys, with this advanced technology, we get to save lives. And I feel like patients entrust in us as their medical provider to do the right things. And VELscope to me is like a non-negotiable. I think every patient should be offered it. If a patient chooses not to do that, that's fine, but we have to educate them as to why we should do it. We know that the head and neck evaluation that we do, just visually and tactile, can still miss maxillofacial and oral cancer. We know that just a pin dot in their mouth could be a stage 4 cancer, but we're not going to know that unless, and we may not even see it without using something like this. So I don't know. Hands down, I don't think there's any other product that does what VELscope does. There's other things out there, but I've never seen anything at this level. And this technology has been around for a long time in medicine. So why is it that we're not, and why shouldn't we offer this to every single patient? One thing that's really important with medical billing is documentation. We have to have things documented, and we're not just doing an OCS, guys. This is not an OCS, oral cancer screening. We are checking a lot of things when we are doing this head and neck evaluation. We need to have it documented well. And so that would be the other thing that I would say is how are you documenting this, and what are you truly, what are you assessing, and then how are you documenting it? We have to have a reason for billing the things that we do, and this makes it that reason of how we can get a medical payer to pay for an evaluation just based on that maxillofacial and oral cancer screening. What I often see is that OCS, and what does that usually mean? And people put either within normal limits or negative or whatever, what it usually means is we never looked. We got to document well. It's just the reality is periodontal disease used to be the number one reason for lawsuit in dental practices. It's now going to be oral cancer. It's moving on up. It's already happening. It's our responsibility to screen for this. And we have the tools and the technology to do an amazing job doing so. We're not shooting blind anymore. So the fun part, what does this look like? I've showed you a lot of stuff, talked about a lot of stuff, covering a ton of stuff in a short amount of time. I want to show you the real thing, the money. Most people want to know what the money is out of this. And it's about VELscope, but it's also about all the things that go along with the VELscope. Because the VELscope is part of the evaluation. And this is what it looks like for Anthem in California. On average, the VELscope is getting allowed amount is $154. Now, that being said, 154 and is being charged, the allowed amount is 154. Are fees too low for them? They would probably reimburse higher. Pretty cool. You're going to see a lot of variation in what I'm showing you based on the payer. But look at also the evaluation. I've mentioned it a couple times. On average for a 0120, I see about $35 throughout the US being reimbursed to dental practices for that code. What if you thought like a medical physician and you billed out $300 for an eval? Would that be a game changer for your practice? It would. Definitely. Now, also part of this evaluation, what if we did a Panorex? Because what I know is most of my patients were perio, so we did FMXs, and we didn't do the pan because we have that darn frequency issue with dental again, and we could have to do one or other every 3 to 5 years. We all know that they're different x-rays for different reasons, but we kind of let dental insurance dictate when we charge, what we charge, how often we charge. We give so much away, and it's not going to be sustainable for much longer. But I think this is a great thing here. The other thing, we're looking at the charge, the allowed, and yes, this did go to deductible. The patient got a benefit to their deductible. That is a benefit to the patient, because just like you, medical providers are very busy at the end of the year because people know they've met their deductible and they're going to get anything and everything done that they can. Just like they race to the dental practice when they have benefits that are left over. So what they're getting on top of the reimbursement from medical, they're also going to dental and billing it to dental and recouping anything that medical didn't pay, or vice versa. So again, you can bill to both to be paid up to your full fee. Here's another just VELscope through them, and you'll see consistently that allowed amount of 154. Okay, that would be like looking at a fee schedule, and that would be the 154 would be on it. Or it could be 200 in this case because we have 100% allowed amount of what we build. Here is another payer, Aetna, and we have an exam, a fluoride treatment, and VELscope. And you're going to notice a difference in the codes. The difference in the codes are some of the payers want the CDT code. Anthem was one of them. And some of them want to use the actual medical code. So you're going to see here, Aetna actually, we billed out 154 on that VELscope, and they allowed 50. Now I see as low as, I just recently had mine reimbursed at like $20. You know what? Anything that we can get reimbursed for the patient that's not out of pocket, patients appreciate that. They get it. Oh, my insurance didn't pay. Okay. And we're gonna tee up the ball with that anyway. We're gonna do this as a courtesy to try to get better reimbursement and decrease your out-of-pocket costs. And the bigger thing of this is the exam that goes with it. the fluoride treatment, and the VELscope. So this looks a little different just on basic services coming out of hygiene. So our reimbursement for that was 308. That was just from medical. We're going to also submit this to dental and capture whatever they're going to pay on this. So again, remember, we have two different places we can go to.
Kendra, I'm sorry to interrupt, but if this was billed under dental, what do you see on averages in terms of reimbursement with the same
Well,
codes?
it's certainly not this. I don't do any dental billing at all. But on average for a 0120, if that's what it was, it'd be about $35. So just the exams alone are astonishingly different. I see anywhere between 2 and 12 times higher. So it allows us again to slow down a little bit and actually do some of these other things and get reimbursed for it. Why not? At least offer it to our patients. Here's another one with Aetna where you'll see the exam fluoride varnish. These are adults, so fluoride varnish is covered often on adults. We have our VELscope, and then we have a pan as well, a screening pan for maxillofacial cancer. So great opportunity here. And this one, the VELscope was only reimbursed at $12.44. Okay. I mean, it's still better than zero, and it's better than writing it off, because I think a lot of providers write this stuff off. If they do an extra pan without out of that frequency, we write it off. I get it. We love our patients. They're like family, but we do have a business to run. And why do we give it all away? I truly believe it's because we've been brainwashed by this little thing called dental benefits and all of the limitations that come along with it. So we have to really shift our mindset if you want to change the game. Here's Cigna. Cigna, again, theirs was a little bit lower. I can also tell you with Aetna that I've seen as high as $50 with Aetna. So based on the patient's plan, you're sometimes gonna see a variation in the reimbursement rate, but you'll see kind of a general consensus about what each payer pays. And again, remember that this is on top of what dental is paying. And if you are in network, you're probably writing about 40% off. So if we can go back and bill that to medical and recapture any of that, that's a great day. Makes it more doable, I guess. If we look at the evaluations and say we had we were in network and we were going to charge $150 and we got $150 100 times in whatever time frame you want to put out there. It doesn't really matter. What I want you to see is that current dental model, even if we go up to about $40 times $100, look at the difference in production there. It's quite huge. Again, I see on evaluations anywhere between 2 and 12 times higher reimbursement on the medical side. But again, we're getting paid to think, we're getting paid to evaluate and diagnose, and we're getting paid for our time, whether that's FaceTime or non-FaceTime. So what if we looked at VELscope and said, we're going to charge $50 and here's 100 of them. You've got $5,000. Now I know a VELscope does not cost $5,000. We had to do it 100 times at $50. But I want us to start thinking outside the box. What if we offered a comprehensive oral cancer program to our patients? And we're going to tell them, your insurance may pay, it may not. Maybe they don't, maybe they have an HMO insurance and we can't bill it. Okay, then they got to pay it out of pocket. But I think it's important for us to offer those things to our patients. And let them decide if it's the right thing for them. I know that VELscope has a ton of literature and marketing tools to help with that process of offering this to patients. But what if we said, you know what, we're going to offer a VELscope and an orthopanogram at $75 a time. That's $7,500. So easy and such a great service to offer, because what are we missing if we don't do it? Don't know. kind of shooting in the dark. So we need to start thinking outside the box. We've got to start looking at what our patients want and what do they deserve to be offered. Now, what happens if we find an abnormal radiographic finding? That diagnosis code is R93.0. Guess what? We can move to a CT and try to diagnose even further. Now, here's where I see a huge opportunity as well when we move to CT, whether it's for oral cancer or any other thing. If we go to a 2D to a 3D, we have an abnormal radiographic finding. I often see practices write this off because they don't know how to bill it to medical. They don't want to charge their patients. You have a $150,000 machine sitting there collecting no ROI. So one thing in your practice that can collect ROI and easily. So here's a CT. We saw an abnormal radiographic finding that we needed to diagnose further or send off to an oral surgeon. But look at that. $375 was allowed and paid. Now, what if we did that 25 times a month for whether it be for something, an abnormal lesion or anything else in our practice? Stuff walks through all the time. Most people, once they have a CT machine, they want to do it on everybody because they see so much more. What happens if that's 12 times a month? Or for 12 months, I'm sorry. We did 25 CTs at $375 for 12 months. That's $112,000. What if you didn't feel comfortable at $375 and you only want to charge $175? I don't care, charge something. But look at the opportunity there, just in an advanced level of diagnosis. It's pretty huge. And we get to do this in our practices. We don't have to send them to an imaging center. So with surgery, you can actually take a CT the day that you do the evaluation. So the eval and the CT gets billed to medical. The day of surgery, you can take another CT to assess that there's no complications, that the mandibular nerve or the sinus hadn't had communication or anything like that during surgery. And then you can take one 91 days post-operatively for an exam and a CT again. So now we've 3x that, and look at the revenue on that you could be leaving on the table. So showing you guys the money, because at the end of the day, that is important. So here is an eval, an orthopanogram, a CT, and a tomographic study. You can bill all three of those x-rays out on the same day. There is no frequencies. They are very different in nature, and they are all billable and payable services by medical. You're going to see the same thing here. That looks probably a little different than what most people are doing in their practices, and that's okay. My goal is to just give you an idea of what's possible. Here is on my not my Facebook page, my website, there is a resource page, and this was in the 2023 dental economics, and they actually just reran this recently. But I basically took from a provider that's in network on the dental side and the medical side of this particular carrier, and I said, okay, let's line up the items, and what is the reimbursement on the dental versus medical side, and it was 2 to 12 times higher from medical. So there is my QR code for my website. If you want to take a quick snapshot of that, you can just go to tipsmedicalbilling.com and go to the resource page, and you'll find this at the bottom. There's tons of different videos, but it's just astonishing to me. When we look at overall medical dental billing and all the things, that go along with some of the procedures we do, but guess what? Dental doesn't cover half of them. They're excluded. Okay. Well, even if they did cover them and you had $8,000 that dental was willing to pay, you're now past their $1,000 to $1,500 benefit for the year. So what do we have to lose to build a medical? There's definitely the ROI. There's no doubt. Things that you want to consider. I think it's pretty crazy. Again, another professional in our industry retired, ended up getting cancer. He had cancer treatment and he received this at the beginning of the year of what his bills totaled and were paid to medical providers that treated him. So you're looking at almost $1 million that were paid to the medical community for one patient. We have to see 1,000 patients get reimbursed $1,000 per patient to be a $1 million practice. What's wrong with that? That's insane. You have to see a lot of patients and maximize that $1,000 every year. And we do that. We chase our tails every year, every month, trying to get to that $1,000 max for every single patient. And we fall down, we get back up, and we do it all over again the next day. Look familiar? So is there something different to consider? And for me, the biggest thing is just what are the opportunities that I get so excited about all the things that we can provide to our patients. I feel when we do the right things for our patients, you're going to see an increase in profit. You're going to see an increase in case acceptance. I never had a problem with case acceptance because I came from the heart and from all the passion that I have for what I do as a clinician. You're going to decrease the patients out of pocket. You're going to save dental benefits for dental, significant ROI, and you're going to be paid as a medical specialty. My goal is to continue to close this gap between medical and dental. We need to. We need to be seen as medical specialists. I hope after just seeing a glimpse of this, you're starting to see like, wow, you're not just a dentist, you're not just a hygienist or assistant. We're healthcare professionals and we need to be reimbursed as such. I really truly believe that. Opportunities are there. If you want to have more information about what I do, feel free to reach out to me. My biggest success has been with working in tandem with practices one-on-one. I'm a little hoarse today because I got off of about 6 or 7 hours of calls because that's how much time I spend with my clients trying to make sure that they're not floundering through this process and not being successful at it. So if that's something that you want, and this is on my website too, because Eben is kind enough to have me here, I do a complimentary analysis to just really put your numbers to work and see, like, does this make sense for you? So if that's something you want, you can go right to that page and fill out your information. I'll get back to you and we'll get your numbers crunched and see if it's the right fit for you. Here's my information again. I had it at the beginning as well, my QR code. Eben, I really truly appreciate being on tonight. And I really appreciate that that Elaine from Dental Lasers was able to provide the CE. So thank you so much. That was a lot of information. I feel like I just need to breathe myself now. So I have the other last minute reminder again, if anybody didn't see this, the CEs, Eben's going to give that QR code here in just a minute. And the confirmation will then also be sent to you via email. So with that, I am going to take any Q&A questions, and then Eben, we don't have a ton of time for Q&A, but we'll do the best we can to try to answer a few things. And again, after Eben gives the QR code, I am more than happy to stay on and answer any other questions that people have. So please put them in the chat.
Thank you so much, Kendra. So we do have a few questions. We'll say one, I hear that that the procedures are billable, but how frequently are they paid? And are we submitting with our office fee schedule or using inflated medical fees just like hospitals? I don't know if that makes sense.
Whatever you bill to dental, you're going to bill to medical. Now, as you learn what those allowances are on the medical side, you may make some decisions to increase your fee. You're not inflating them just to go to medical. You're going to use the same. That would be fraudulent to say I'm going to bill $50 to dental, but if I'm going to go to medical, I'm going to bill $100. That would be fraudulent to do
So
that.
your fees have to be consistent.
Yes.
Gotcha.
Yes.
Okay, awesome. So next question, how can we bill medical insurance without a medical license number? And I think this is a really good question because we've had a conversation about
Yeah,
credentialing.
yeah, have an N, you have an NPA, you have an NPI, and that's what you bill with. That's no different. And credentialing, that word is used a little loosely. You can credential as a par or non-par provider, an in or out of network provider. Most people, if they've had their practice for many years, your NPI is loaded into the carrier systems, and you don't have to do anything. You just Most of my clients, we just start submitting claims and they go through. Where I see a problem is if you have a new NPI or new tax ID that maybe isn't loaded in their system. But it's usually not a big deal. They cannot discriminate against your provider type. So if they're willing to pay an ENT for, say, an evaluation, they have to pay you as well. They will
Uh,
try to, but they can't.
so let's get one last question before so we can get to the and again, folks, I see the questions are coming, but so if we bill medical or even dental, I've heard we're liable uh, for examinations. I think the question is more like if you do a CT scan, you see something, now you do a CT, you're now liable if there's something on the CT scan that maybe you don't interpret. So does that then need to be referred for interpretation, like to a
I,
radiologist and so forth?
I think with CT, I think it would be in the best interest to submit it to a radiologist, just like medical does.
Hmm.
I, that we have it in our clinics, so we just do it, and that's beautiful because we can do point of service care that day and we can treat much faster, but that's not how medicine works, and they do bill that out. And they have a radiologist read it. My favorite company is Dental Ray, and they're the only ones that actually have maxillofacial surgeons that are reading their CTs. That's pretty cool because that's important. These guys know what these those that team knows what they're doing when it comes to the reads.
Fantastic. So we have a few more questions and we'll get to them. I just wanted to share some information because obviously the majority of our attendees are VELscope users. So I should have said at the beginning, folks, thank you so much for being part of the VELscope family. And for those that are not, hopefully you'll be looking to join. And I am remiss by saying this is Oral Cancer Awareness Month, and that's sort of the whole premise of having this program because this is all about awareness. And I would say, and I want you to sort of think about what Candra's been talking about in that connection with the more you can share about how you can get a procedure covered, the more it's in line with oral cancer awareness, right? So if it's easier for you to get coverage on the medical, it means it's easier for you to have a conversation with your patients. For our VELscope users, if you are not aware, please, that we now have a 2C certification course. It's the only way that you can be listed as a provider on our website. It is free for VELscope users. You just go to velscope.com, you'll see the 2-hour certification, sign up. Everyone who wants to see has to sign up individually. But again, it's free and it's on demand, so you can stop and go as you so desire. But I will tell you, the results have been pretty incredible in terms of people that have gone through the exam, both in terms of the level of comfort doing a VELscope exam, as well as patient acceptance, because we know that one of the key criteria is how do we convey the value to that patient. So I think you'll find it very beneficial for anyone and everyone. And it's not just for clinicians, it's also for your staff as well. Another thing that I wanted to share, we're really excited about. You are literally the first group that are getting exposed to this. There is a new VELscope coming out. It's called the VELscope Mantis, probably targeting June shipping, but available for purchase in beginning of May. But it's unlike anything else out there. It's got white light, it's got a fluorescent light, and it provides the ability to integrate with a iPhone. So you literally can take pictures just by holding the handle and zoom in and out. It is so slick and so many advantages over the existing product, of which, again, you can find more information hopefully very soon. And then lastly, here's your CE code or QR code. So with that, I'm going to plug in the link in a second. I should have done that already, but hit the QR code. It's a simple form to fill out. What'll happen is you will get your CE certificate in about a week. It will be coming from Dental Laser Integrations. So please, if you haven't got it, check your spam just in case it went into spam. A lot of times, people saying I haven't got it, and then it's obviously in a different folder. So again, you should get about a week. If it's been more than a week, week and a half, don't hesitate to reach out to us. But I think you'll find it to be, pretty seamless in that regard. And again, Dental Laser Hygienics is fantastic in regards to supporting us. So with that, I guess we will let you folks go. I'm trying to see. Here goes I'm sorry, folks. Here goes the link. So if you don't have a cell phone, or if you have a cell phone or what have you, or obviously you can hit the link if it's easier for you. So thank you again for your time. We really appreciate it. This has been recorded, so this will be uploaded to our website in a couple of days. And so obviously you can come back in, maybe learn more information, but I would highly recommend it seems, Kendra, I'm gonna open up, folks, to save time, but I'm gonna open up a few questions. And Kendra, one of the things that I know in talking with people it seems complicated. It's like a different language and it's intimidating for folks. I know your whole focus is training. You don't do the billing yourself. It's just how do you get offices to do it? And I think how do you allay that trepidation or the concerns of, God, I just don't have the bandwidth to learn something completely new, even though there's so many benefits associated with it.
Well, that really varies on the practice I'm working with and the people within that practice. I think great leadership is part of that. If the team wants to, I don't know. I guess I always came from such a big team environment, and we did whatever we could for our patients and for our practice. Um, and I just, I just look at overall how much patients are paying out of pocket and how much limiting belief we have around what we can and can't afford, or what the patient can or can't afford. And this just gives us a whole nother opportunity. Like I said, we're chasing that $1,000 benefit. When we look at medical, there's no limit. And you can be reimbursed more. I think, it can be scary for people like anything new, but you that's why I do what I do, and I work so closely with my clients. I'm on calls with them every single week, because you do have to hear these things multiple times, and you just need somebody to kind of walk you through it. And it really it takes a little while to shift your mindset towards medical. But trust me when I say, I mean, I wouldn't still be in business if this didn't work, and if patients weren't being served well. Coming from the dental world and being a clinician, I just know how hard we work. And I know how much we put into it and how much we love our patients. But, you know, we need to start looking at how can we be reimbursed for that too. We need to start thinking differently. So the I think I probably went off grid on that one, Eben, but it is scary always having something new. It's just like if you get a new CEREC machine and you don't do the training, you're going to hate the CEREC machine. You're going to say it does a really cruddy crown. Well, it's the same thing. But if you're ready to take the plunge and do it, our goal is, we may have to shift our approach every once in a while, but our goal is to make this successful. And I'm here to make sure that you get it to where you want it to be and successful in your practice. So, it's a different, I think my niche is very different than a lot of people out there in that process. Because while it's similar, it's different. And my goal is to not have you flounder through it, and I'm there every step of the way with you.
I know some people, I'm sending you the link via chat, so bear with us for those that didn't get it for some reason. I guess if you build medical, do you build dental like a secondary, and then are you in the network? Are you are you an in-network dentist? Do you honor the dental contract and write off the deductible?
You have to. Yep. So if you inflate I shouldn't use the word inflate. If you increase your fee to meet a medical model, and you're in network with dental and you're submitting it to dental as well, um, you can't collect you have to follow the dental contract. So you're not out anything, but while you're trying to recoup what you were, potentially writing off. So yes,
Uh,
you do have to honor your contract from dental.
and so just to reiterate, you can bill medical, and then whatever you didn't get reimbursed, you can bill that difference to dental.
Yeah, and a lot of people are like, well, do we have to go to dental or medical first? And in state insurance commissioners that I've talked to, there is no right or wrong with what that looks like. So if we have a prior auth on the medical side, we're definitely going to go to medical first. And if there's anything left over, we're going to go to dental. But the thing to remember is if you have larger procedures that you're billing out and you bill it to medical, and the patient only has $1,000 benefit, is it really great for the patient to utilize those other benefits or not? I mean, there's every practice has a different philosophy, and it's not for me to choose what that should or shouldn't be. But you have to do what's right for you and your practice and what feels okay for you.
So two other quick questions. So if you're, and I know this sounds biased, but I think one of the things that you said, Kendra, was, and why I thought this was so beneficial, is that yes, some things are more complicated than others. You were showing examples where you have one procedure and there could be multiple codes associated with that procedure. You have things like VELscope, which is a great introduction because it's a simple code that you are using. But the great thing is you combine that with other simple codes as well, like, your PAN and so forth. So I
Right.
guess my question is if you're looking to get started, you know, theoretically, you could just do five or whatever, how many patients, 8 patients a day that you submit just for these preventative screenings and get
Absolutely.
comfortable with that before you consider expanding.
Correct. And I have that a lot by general dentists. Well, I don't know if I have enough procedures to build a medical. If you're leaving money on the table for these basic things like an exam, pan, CT, VELscope, fluoride, those are easy peasy claims to get reimbursement without a lot of effort. So yeah, you do have things to fill. So there's lots of opportunity. You just have to decide what do you want to go after. And this is a great entry point because you have to start somewhere, get your system down, and then just continue to ramp up till you have
Right.
everything incorporated that you want. But it's a super easy entry point with and that's part of why we're doing what we're doing, to show
So,
you how easy that can be.
so thanks, Kendra. I guess another question sort of delves into this as well indirectly, but one of the things obviously you train officers in doing is so you get the medical card because that gives you the direction of to whom to bill that claim to.
Right.
So, because the question is, I'm confused, who do I send the claim to? Obviously, you're gonna show them exactly how you process a medical claim to maximize that. Well, number one, to submit the claim in the first place in order to achieve the goal of reimbursement. But then obviously the next point is how you're submitting the claim in terms of the codes and so forth.
Yeah, and we have to have a different system of submission for claims because your dental software is not going to do that for you. So, this was a really quick overview. I mean, there's so much more detail, and I'm not saying that to be scary, but to do it right. To do it right, you have to know what that is, and those are the things that I help my clients with. Um, it's the same RCM system or revenue cycle management that you have for dental, but now we're just moving it to medical. So you already have that knowledge and you already know how to bill and how to follow up on claims. Now we're just doing it on the medical side. So I think yeah, it's just a little different.
Great question from Jill. So, do you need a pre-auth or can you just bill medical?
You can just bill medical. For the things for the VELscope, the fluoride, the pan, the um any of those things that are just basic like that, you do not need a pre-auth. When you talk about surgical things, then you're going to need pre-auth. Sometimes sleep apnea appliances, sometimes um, TMJ appliances, those are all things that we'd want to investigate. They're also more expensive things. So we want to do our homework a little bit more thoroughly on some of those things. But these basic things, you can submit those all day long without a pre-auth. You don't need one.
And I guess one last question, and again, I know this comes into your training. You have people that do medical billing, which I know there's so much variability on, which I think to some degree have caused some of the issue when it comes to people's perspective of medical billing. So what is your perspective when it comes to being able to do it yourself versus using a service?
Well, there's only one company that I recommend for a service, because I know that they have the same core values that I have, which is integrity, ethic. They're going to do things ethically and they're going to be transparent. And there's a lot of companies out there right now that are not doing that. And I know that they're doing fraudulent things because I've seen it. And unfortunately, most practices don't know that. And the person that's going to be in trouble for that fraud is the doctor's NPI that's on the claim. And there's some companies that aren't even putting the doctor's NPI as the rendering provider. They're using their companies, which is totally illegal. But you hire a service and you assume that they're doing things right. And unfortunately, ignorance doesn't win in court.
Yeah, so I guess again, folks, I really don't mean to pub Canva, but I'm telling you, her focus and dedication to this aspect is it's so amazing. So, it's just worth just having conversation, especially if you ever used someone for medical billing in the past or considered it. So I think we've answered most of the questions. Here's my contact information. Kendra had provided hers. If you didn't get it, but you still want information, please reach out to me or anyone at VELscope and we'll get you what you need. But we thank you so much for your time, your participation. Obviously, all the questions say that there's interest. And so I would definitely make sure to explore. And the last thing is we will be at CDA for our Southern California participants. So hopefully check us out because we're actually launching the new VELscope at the CDA. So in the meantime, again, anything you need, any questions, any follow-up questions that you may have for Kendra, please reach out. And again, have a great, happy Friday, a good Friday, and happy Easter.
Yes, thanks everybody for joining. A lot of people stayed on for the Q&A, and that I love that.
Awesome.
Love that.
Yeah, I think we got them all. So, Kendra, thank you so much for your time. Really appreciate you sharing your knowledge, and we look forward to working with you soon or doing another program again soon. And again, folks, this will be on our website as a recorded venue. So, anything you missed, you can please go to there. Take care. Thanks, Kendra.
All right, do you have everybody signed off or no?
Oops. No.
Did you
There's
stop?